we'll continue with the neonatology class, and there are a few other topics that need to be completed, after which we'll move on to congenital heart disorders. The next topic that I would like to start with is a topic which is again very important for your examination point of view, which is birth asphyxia. Birth asphyxia or perinatal asphyxia, as it is commonly called. So the another name of birth asphyxia is perinatal asphyxia. Perinatal asphyxia. So birth asphyxia or perinatal asphyxia, as it is commonly called, is a condition which occurs because of reduced blood supply plus hypoxia in a newborn, which occurs before, at, or after birth. So what is happening here is that the blood supply to a newborn is usually reduced. Either the reduced blood supply was before the time of birth, that is during the time of pregnancy, or it was at the time of delivery, or it is just immediately after delivery. So anything that reduces the blood, example, I'm giving you a very simple example. During the time of pregnancy, there was a condition which is known as abruptio placenta. So the placenta got detached. At the moment the placenta gets detached, the blood supply to the fetus gets cut off. Or during the time of delivery, the moment the child is born, there is a cord prolapse. That means the child's head compresses the umbilical cord immediately after delivery. So that blood which was coming to the child suddenly stops. So the moment there is stoppage of the blood supply, resulting in hypoxia in a newborn, either before, at, or after birth, then this condition is known as birth asphyxia, or in common terms perinatal asphyxia. Both of them means the same thing. Now please, before you start writing anything, just understand what I am saying. Just hear what I am saying. Please try to understand first what I am saying. Then you can write whatever you want to write. See, initially whenever the blood supply to the child stops, oxygen to the child stops, the first and the most important organ that is at a risk of hypoxia is the brain, and probably to some extent the heart. So the brain and the heart are the two most important organs that are at a risk of infarction. And you know the consequences of the blood supply stopping to the brain can be immense. So therefore, all the organs of the body, apart from the brain and heart, they try to help the brain. And how do the organs, they help the brain in the case of a newborn? Blood from all the remaining organs of the body starts to get preferentially diverted towards the brain. So suppose blood supply to the body of a child gets stopped. So as a result, what will happen? The shunting of blood starts from the different organs of the body towards the heart. So you can see shunting is happening from the kidney, it is happening from the gut, it is happening from the liver, it is happening from the lung, it is happening from the spleen. And all this blood, which should have ideally gone to these organs, will start going towards the brain. So whatever little blood is now left, that is now going towards the brain. So the brain is the organ which all these organs are trying to protect. So whenever a perinatal asphyxia occurs, try to understand what I am saying. Whenever a perinatal asphyxia occurs, which means the blood supply to the newborn stops, the most important consequences which start happening initially are always in these organs. Brain actually is protected initially. And why is it protected initially? Because initially, most of the blood from these different organs are getting diverted towards the brain. So the body is trying to protect the brain, but at what cost? At the cost of ischemia or lack of blood supply or reduced blood supply to the kidneys, to the intestines, to the liver, to the lungs, and to the spleen. So the initial consequences of perinatal asphyxia are suffered by these organs, and one of the first organ to suffer the consequences is the kidney. So which is the first organ where the consequences occur? It is the kidney. and the acute renal failure starts to happen because now the kidney stops getting blood. Why is it not getting blood? Because this blood is getting diverted towards the brain. So the first organ to get affected is the kidneys, and the first manifestation of perinatal asphyxia is acute renal failure. So this is the first manifestation. Of perinatal asphyxia. First manifestation of birth asphyxia or perinatal asphyxia is the acute renal failure, involvement of the kidneys because of ischemia. Why is the kidney suffering from ischemia? Kidneys are suffering from ischemia in birth asphyxia because this blood is getting diverted towards the brain to protect the brain. So this is the first organ to start getting affected. The next organ to start getting affected is the intestines. You can see here intestines, the gut is also getting affected. So intestines are getting affected. So when the intestines are getting affected, because the blood is again getting diverted towards the intestine, what will happen is manifestation of intestinal ischemia. Because what is this manifestation called? It is known as necrotizing enterocolitis. So what is the manifestation of kidney ischemia? Whenever there is a condition of perinatal asphyxia, what is the condition that results because of ischemia to the kidneys? It is acute renal failure. What is the consequence of ischemia to the intestines in perinatal asphyxia? It is necrotizing enterocolitis, NEC in short. It is also called as necrotizing enterocolitis, in short NEC. Now I'll just discuss this NEC in a little more detail. Please try to understand this and I'll come back to that previous slide. But first just let us study NEC in a little detail. See, what is necrotizing enterocolitis? In short, it is also called as NEC. NEC, please try to understand. NEC is a condition which is more commonly seen in premature infants in comparison to mature infants. The most common reason why a necrotizing enterocolitis occurs, the most common reason why a necrotizing enterocolitis occurs is when a premature child is exposed to formula feeds. Formula feeds are feeds that are given usually through the bottles. So this child is not getting breast milk. This child is getting formula milk through the bottles very early in life. This is the typical setting when NEC occurs. A child who is a preterm, despite our saying to the mother, please do not give outside milk to a newborn. Only newborn should receive breast milk. Despite our telling this multiple times, the mother of this preterm child starts the child on a formula milk, say for example a cow's milk or a milk which is basically a bottled milk or a milk which is a powdered milk, and this milk is given in bottles to the child. So now please try to understand what will happen. The milk that is given from outside will introduce infection to the intestine, so there will be infections. There will be infection of the intestine. In addition, when you give too much of milk very early in life, please try to understand, when you give too much milk very early in life, there will be increased oxygen demand in the intestine. And this oxygen demand in the intestine will be added on further by the infection that is present in the intestine. Please try to understand this. Bottle milk which is given to a child, bottle milk which is given to a preterm child in preterm will introduce infections of the intestine. So bottle milk which is given in preterms will introduce infection in the intestine. You did not give the child breast milk, you gave the child bottle milk. This will introduce infection in the intestine. Along with this breast milk that has the bottle milk that has entered into the intestine will increase the oxygen demand inside the intestine. Both bottle milk that is given and the infection, what it will do, both of them will contribute to increasing the oxygen demand in the intestine. But there is already an asphyxia, the child is not getting enough amount of oxygen or enough amount of blood supply. So this will cause ischemia of the intestine. What it will cause? It will cause ischemia of the intestine. Now, whenever there will be ischemia of the intestine, what will happen is there will be damage to the intestinal mucosa. Damage to the intestinal mucosa. Because of the ischemia, there is damage to the intestinal mucosa. And when there is damage to the intestinal mucosa, what will happen is certain toll-like receptors 4. This is certain receptors which are present below the mucosa get exposed, and to this bacteria attach. So bacteria which are already present inside the intestine because of the intestinal infection, what will happen? The bacteria will attach to the toll-like receptors TLR4 which are present just below the intestinal mucosa. And why is these receptors exposed? Because the intestinal mucosa has got damaged. Why is it got damaged? It has got damaged because of intestinal ischemia. So as a result, what will happen is this will cause intestinal inflammation, plus further breakdown of intestinal of the intestinal walls. So inflammation will cause further damage to the intestinal wall, and those bacteria which till now were present inside the intestinal lumen will then invade into the body of the child, leading to neonatal sepsis. So invasion of the bacteria from the lumen of the intestine into the peritoneum, causing sepsis. This is how necrotizing enterocolitis developed. It was just a small thing that started with. Please see this. It was just a small thing. Bottle milk was given very early in a preterm child. Very early in life, bottle milk was started. Breast milk is what is ideally recommended, but bottle milk was started in the preterm child. This bottle milk introduced infection into the intestine. So what was the second thing? Infection occurred into the intestine. Both the milk that was given very early in the intestine and infection, they contribute to increase in the oxygen demand inside the intestine. Now the intestine oxygen demand is very high, but blood supply to the body has been cut off because it is a case of perinatal asphyxia. So intestine blood is not getting, all of it is getting diverted towards the brain. So intestinal ischemia will start to occur. This will cause intestinal ischemia, lack of blood supply to the intestinal walls. This obviously will start causing damage to the intestinal mucosa. So now there will be damage to the intestinal mucosa. Now when the mucosa of the intestine, they start getting damaged, eroded, there are certain receptors which bind to the bacteria, and these receptors are present below the intestinal mucosa. What are these receptors called? They are known as TLR4 or toll-like receptors. They get exposed and the bacteria, they attach to these receptors. Bacteria were already present in the lumen. They attach to these receptors. So the moment the bacteria have attached to these receptors, now what happened? This will start causing intestinal inflammation. So in short, necrotizing enterocolitis is an inflammatory disorder of the intestine. How do we classify? It is an inflammatory disorder of the intestine. So intestinal inflammation will occur. And how is the intestinal inflammation occurring? Because the bacteria are binding to the toll-like receptors which are present in the intestinal wall, just below the mucosa. And this intestinal intestinal inflammation will further cause breakdown of the intestinal wall. Breakdown is already occurring because of ischemia. This will cause further breakdown of the intestinal walls. And when there is further breakdown of the intestinal walls, air which was present in the intestinal lumen, and the bacteria which are present in the intestinal lumen, they further invade into the intestine, and ultimately there is a big hole in the intestine, and these bacteria can invade into the peritoneum also, causing widespread septicemia, sepsis. So a simple problem that started by giving bottle milk very early, formula milk very early to a preterm child, resulted in intestinal inflammation, intestinal damage, and widespread septicemia. This is how necrotizing enterocolitis evolves. I'll again repeat this so that there is no confusion at all. See, necrotizing enterocolitis predominantly occurs in premature infants. If someone asks you, what is the biggest risk factor for necrotizing enterocolitis? It occurs in premature infants. In a mature infant, it will only occur when there is birth asphyxia, perinatal asphyxia. We are studying NEC under perinatal asphyxia. So in a term child, it will occur only if the child is having a birth asphyxia. But in a preterm child, birth asphyxia may be present, birth asphyxia may not be present. But if you start bottle milk in a preterm child very early in life, this will introduce infection into intestinal lumen. Obviously, you are not cleaning the bottles again and again. So this will introduce infection into the intestine. Infection in the intestine along with milk that is entering into the intestine will increase the oxygen demand in the intestine, because the intestines have to contract. So there will be increased oxygen requirement. But at the time when there is already an ischemia, the oxygen cannot be met. So this will lead to further ischemia of the intestine walls. Once the ischemia starts happening to the intestinal walls, obviously the inside of the intestine, the mucosa, starts getting damaged. It starts getting eroded. So what is the fifth point? Fifth point is damage to the intestinal mucosa. Once the intestinal mucosa gets damaged, the toll-like receptors which are present below the intestinal mucosa, these are adhesion receptors for the bacteria, for binding the bacteria. So the moment these receptors are exposed, bacteria which are present in the lumen bind to these receptors. And the moment they bind to these receptors, there is inflammation of the intestine. So which group of disorders does NEC lie in? NEC is a type of an intestinal inflammatory disorder. And this intestinal inflammation will cause further damage to the intestinal walls. So already damage is occurring because of ischemia. It will cause further damage to the intestinal walls to the extent that there can be a big opening in the intestinal wall, leading to air and leading to the bacteria invading into the peritoneum, leading to widespread septicemia or sepsis. And this can even lead to the death of a child. What is this condition called? This condition is known as necrotizing enterocolitis. So please try to understand again and again what I am saying. NEC, please try to understand. Necrotizing enterocolitis, most commonly it occurs in preterm infants. So most common risk factor is preterm. More premature is the child, higher is the risk of NEC. A 28-weeker child is at a higher risk of NEC compared to a 32-weeker child. So more premature the child, higher the risk of NEC. But in a term child, NEC will only occur when there is perinatal asphyxia or birth asphyxia. Otherwise, if there is no birth asphyxia, a term child will not develop NEC. A preterm will develop NEC even without a perinatal asphyxia if the child is started formula milk, bottle milk very early in life. They do not require, preterms do not require the presence of the birth asphyxia. So most common risk factor for NEC is prematurity, preterm child. How does the NEC manifests? So signs and symptoms of NEC. NEC classically presents with abdominal distension. Then there is reduced bowel sounds. So when you are putting a stethoscope over the abdomen, the bowel sounds appear to be reduced. They reduce bowel sounds. And because the intestinal mucosa, remember intestinal mucosa was getting damaged. So they will be bleeding inside the intestine, which obviously will appear in stools. So they will be bleeding in stools. In addition, there will also be feed intolerance. What is meant by feed intolerance? That means when you give milk to the child, the milk cannot pass through the stomach into the intestine because the intestines have gone into a state of intestinal obstruction because of the damage. So the feed will keep, or whatever feed you are giving to the child will keep on collecting, and the child may start even vomiting. This is what is called as feed intolerance. So any child who has abdominal distension, who has reduced bowel sounds, who has bleeding in the stools, and who has feed intolerance, and especially if that child is a premature child or a preterm child, think of necrotizing enterocolitis. I hope you have understood. Any child who is having abdominal distension, who is having reduced bowel sounds, who is having bleeding in the stools, and who is having feed intolerance, this is one disorder you should definitely think of, particularly if that child is a preterm child. X-ray features of NEC are very typical. There are 3 X-ray features that you should think of. Initially, please try to understand again. Initially, when the intestinal mucosa gets damaged, the air which is present in the intestinal mucosa, it enters into, mucosa is getting damaged. So the air will enter into the intestinal walls. And you can see air in the intestinal walls or gas in the intestinal walls. What is this condition called as? This X-ray is called as pneumatosis intestinalis. What is this condition called? This is known as pneumatosis intestinalis. Air which is present in the intestinal walls. This is a pathognomonic sign. Pathognomonic sign means if this sign is present, you can say, closing your eyes, this is NEC. Air inside the intestinal wall, this X-ray is known as pneumatosis. Pneumatosis means gas. Intestinals, gas in the intestinal walls. Gas should be inside the lumen of the intestine, not inside the walls. If you still do not pay any attention, the damage to the intestinal wall keeps on increasing. I told you, infection and inflammation will further damage the intestinal wall, and now you will have air or gas which will be present in the portal vein in the next step. Now air is not limited to the intestinal wall. Air now enters into the portal vein. This is known as pneumoportalis. What is it called? It is called as pneumoportalis. Pneumoportalis means air inside the portal vein seen on an X-ray or maybe seen on an ultrasound. And finally, if you still do not pay any attention, there will be a complete breakdown of the intestinal wall, leading to air from the intestine now entering into the peritoneum. Air in the peritoneum. This is known as pneumo. Pneumo means air. Pneumoperitoneum, air inside the peritoneal cavity. These are the 3 classical X-ray pictures seen in necrotizing enterocolitis. Pneumatosis intestinalis, air inside the intestinal walls. Pneumoportalis, air inside the portal vein. And pneumoperitoneum, air inside the peritoneal cavity. All of which has occurred because of the damage that has occurred to the intestinal wall. And the damage has occurred because of 2 reasons. First is inflammation, second is ischemia. Ischemia and inflammation, both starting by infections. How you suspect NEC? Any preterm child who has abdominal distension, reduced bowel sounds, bleeding in the stools, and feed intolerance. That means more and more feed you give, the abdomen becomes more and more distended. That means now the milk is not passing through the intestines. This is basically one of the first signature or first indicator of the child having a possible necrotizing enterocolitis. Risk very high in a preterm child, but can occur in a term child only when there is birth asphyxia. I hope this is pretty clear to you. What are the three X-ray features of NEC? Pneumatosis intestinalis, pneumoportalis, and pneumoperitoneum. Pneumatosis intestinalis, air in the intestinal walls. Pneumoportalis, air inside the portal vein. And pneumoperitoneum, air inside the peritoneal cavity. There is a staging system that is used for NEC. Staging system for severity of NEC. I will not go into the details of the staging system, but the staging system for the severity of NEC is known as Bell staging system. This again is an FMG question. Which staging system is commonly used for staging the severity of NEC? It is the Bell staging system. Bell staging system divides NEC into three stages or three grades. Stage 1, which is further divided into stage 1A and stage 1B. Stage 2, which is further divided into stage 2A and stage 2B. And stage 3, which is further divided into stage 3A and stage 3B. So there are total how many stages? Stage 1A, 1B. NEC keeps on progressing. Stage 2A, 2B. And then the advanced complication stage, which is stage 3A and 3B. So 6 stages in total. Please remember, this has not been asked in FMG, but has been asked in PG entrance exam. I told you 3 X-ray pictures. First X-ray picture was pneumatosis intestinalis, which was air in the intestinal wall. Second X-ray picture was pneumoportalis, and the third X-ray picture was pneumoperitoneum. So, the only thing that you need to know is that pneumatosis intestinalis is seen in which stage? Pneumatosis intestinalis. Second, pneumoportalis is seen in which stage? And third, pneumoperitoneum is seen in which stage? And when I say which stage, that means stage of Bell staging. So pneumatosis intestinalis is seen in Bell stage 2A. Pneumoportalis seen in Bell stage 2B. And pneumoperitoneum is seen in Bell stage 3B. So pneumatosis intestinalis seen in Bell stage 2A. Pneumoportalis seen in Bell stage 2B. And pneumoperitoneum is seen in Bell stage 3B. So I think it is now pretty clear. Leave aside the FMG questions. If you are asked an essay to be written on necrotizing enterocolitis, you can, I think, write now a 2-page essay or a 3-page essay on necrotizing enterocolitis. So I again quickly will repeat, necrotizing enterocolitis, I started by saying that more premature the child, higher is the risk of NEC. Problem starts when you give bottled milk to a preterm child very early in life. So infections will lead to increase in the oxygen demand along with the blood supply. Then you see, fourth number, the intestinal ischemia will start to happen because oxygen demand to the intestine has increased, but this blood supply is not being met. So there will be ischemia of the intestine, which will cause damage to the intestinal walls, exposure of the toll-like receptors below the mucosa, which will bind to the bacteria. As a result, intestinal inflammation. So this is an inflammatory disorder of the intestine. Then there will be invasion of the bacteria from the lumen into the walls of the intestine and into the peritoneal cavity, leading to septicemias. Then I told you the signs and symptoms can include abdominal distension, reduced bowel sounds, bleeding in stools, and feed intolerance. The typical X-ray pictures can be air in the intestinal wall, which is known as pneumatosis intestinalis, air in the portal vein, which is known as pneumoportalis, and air in the peritoneum, which is known as pneumoperitoneum. So pneumatosis intestinalis seen in Bell stage 2A, pneumoportalis seen in Bell stage 2B, and pneumoperitoneum seen in Bell stage 3B. I will not go into the details of the treatment of NEC. Treatment of NEC usually depends upon the stage. Most of the cases of stage 1, 1A and 1B. Here it is probable NEC. You still are not very sure, but these children can be managed just by restricting the feeds of the child. Similarly, in stage 2, because here the risk of infection has increased. Now this is definite NEC. The risk of infection has increased. So here you start the child on antibiotics. Then other management including stomach decompression. Here what you do is you put in a feeding tube into the stomach, and whatever milk is present in the intestine, just aspirate that milk out. Reason being very simple, that milk is what is causing all the infection into the intestine. So that needs to be aspirated out. And then other supportive medical management. And stage 3 obviously is the stage when surgeries are required. Now this is basically the most dangerous stage of complications. So surgeries are required with other management options. So this is how you manage necrotizing enterocolitis. Right? So let us now come back to the original topic that we were doing. So we were doing necrotizing enterocolitis, and I said intestines, when it get affected, then it leads to necrotizing enterocolitis. I told you the severity classification of NEC is done by the Bell staging system, which is divided into stage 1A, 1B, 2A, 2B, 3A, 3. I've already done this. No need to go into the details of this. Then certain other complications. The metabolic complications of necrotizing enterocolitis include hypoglycemia, hypocalcemia, and hyponatremia. Hyponatremia is low sodium. So I've already told you what is hypoglycemia in a neonate. I've already told you hypocalcemia in a neonate. And I've told you conditions in which both hypoglycemia and hypocalcemia occur. Which were the conditions? We talked yesterday about IUGR. We yesterday talked about prematurity. Today I talked about infant of diabetic mothers. All of them have neonatal hypoglycemia and neonatal hypocalcemia. Now I am telling you another important disorder which can be associated with neonatal hypoglycemia and hypocalcemia. Which is that disorder? Birth asphyxia. So in a birth asphyxia, when you are managing birth asphyxia, you have to give glucose to a child because this child often has hypoglycemia. You have to give calcium to a child because this child often has hypocalcemia, and you have to give normal saline to a child because this child has hyponatremia. Normal saline because hyponatremia is present. What is hyponatremia? Hyponatremia is low sodium in a child. Hypoglycemia, hypocalcemia, hyponatremia, all of them are complications of birth asphyxia, perinatal asphyxia. So you are understanding, various organs are getting affected. Various organs are getting affected in NEC. Kidneys are getting affected, gut is getting affected, liver is getting affected, lungs are getting affected, spleen is getting affected, all the organs are getting affected because the blood from these organs is being transferred towards the brain. However, till how long will brain be protected? Because if this perinatal asphyxia continues, then ultimately what will happen is brain will also start getting involved. And when brain starts getting involved, then there are certain problems that happen in the brain because of ischemia. What is that condition called? When brain finally gets involved. When brain finally gets involved, this condition is known as hypoxic ischemic encephalopathy. What is it called? It is called as hypoxic ischemic encephalopathy. In short, HIE. You understand? When kidneys get affected in birth asphyxia, renal failure. Intestines get affected in birth asphyxia, necrotizing enterocolitis. But when brain gets affected in birth asphyxia, then the condition is known as hypoxic ischemic encephalopathy. Students often ask me, sir, what is the difference between birth asphyxia and HI? Please remember, again and again I'm saying, birth asphyxia is a multi-organ manifestation. Various organs are getting involved in birth asphyxia because all these organs are trying to protect the brain. But when brain finally gets involved in birth asphyxia, then this condition is known as hypoxemic ischemic encephalopathy. So hypoxic ischemic encephalopathy is a CNS manifestation of birth asphyxia. Like necrotizing enterocolitis is an intestinal manifestation of birth asphyxia, hypoxic ischemic encephalopathy is a CNS manifestation of birth asphyxia. And HI will lead to damage in certain areas of the brain, necrosis of the neurons in certain areas of the brain. The type of damage that occurs in brain will be different in a term infant and in a preterm infant. Let us see first what happens in a term infant when the brain does not get enough. So now we are not talking about birth asphyxia directly, we are talking about brain getting affected in birth asphyxia. And this condition is known as hypoxic ischemic encephalopathy. The first damage, so what is happening in the term newborns is neuronal necrosis. So neurons will start to die because they are not getting enough amount of blood. So we call it as selective neuronal necrosis. So what will happen? Selective neuronal necrosis will start to happen. And where will the selective neuronal necrosis start to happen? The first areas where they will start to happen are these areas. You are seeing these purple shaded areas. These are the areas which are also known as the watershed areas of the brain. What is a watershed area of the brain? A watershed area of the brain is a part of the brain which is not getting a direct blood supply from any of the major arteries, our anterior cerebral artery, middle cerebral artery, posterior cerebral artery. So these watershed areas of the brain do not get direct blood supply from any of the major arteries. So these watershed areas of the brain, the purple shaded areas, are the areas of the brain which normally are highly susceptible to ischemic injury, highly susceptible because they do not get any major blood supply from the arteries. So when birth asphyxia occurs in the brain, that means when hypoxemic ischemic encephalopathy occurs, when hypoxic ischemic encephalopathy occurs, the first neuronal necrosis that start to occur, selective neuronal necrosis start to occur are in these areas. These are the areas where the neurons first start to die, resulting in infarcts which are known as watershed infarcts. Why are these infarcts known as watershed infarcts? Because these are the infarcts that are present in watershed areas of the brain. Watershed areas of the brain are the areas which are not supplied directly by any of the major cerebral arteries. The two arrows that I have marked, these are the watershed areas of the brain. Death of the neurons in these areas will lead to watershed infarcts, also sometimes called as parasagittal injuries. Why are they called as parasagittal injuries? This is the sagittal line, central lines, because they are just adjacent to the sagittal line. This is the sagittal line. This is the sagittal line. So because these are just adjacent to the sagittal line, that is why these are known as parasagittal injuries. So the first type of injury that occurs in hypoxic ischemic encephalopathy is watershed infarcts. The second type of death of neurons that start to occur is in the areas of the gyries. So this type of mushroom shaped gyri, you can see this arrow. This type of mushroom shaped gyri that is formed is known as oligyria or a mushroom shaped gyri. Just pay attention here. See, just pay attention here. These are the normal gyries and sulcis of the brain. You know this. This is the normal gyri. So this is a gyri. This is normally present in the brain. These are the convolutions that are present in the brain. And these are the deep sulcis. Now the gyries are very well perfused. Normally also they have a very good blood supply, very well perfused. But sulcus are very poorly perfused. So whenever ischemia starts to happen, blood is not reaching the brain, the sulci, because they are already very poorly perfused, they are the ones that first start getting susceptible to ischemic injuries. Gyries will remain intact because as such they have been receiving very good amount of blood supply. So what picture will form? See this. Gyries will remain intact while sulcis will start to narrow down. So gyries will remain intact while the sulcis now have narrowed down or have got scarred, resulting in a typical mushroom shaped gyri. What is this mushroom shaped gyri known as? This mushroom shaped gyri is what is known as olighyrias. What is it called? It is called as olighyria. This again is a type of ischemic brain injury that occurs in the brain of a term infant. What was the first injury that occurred in the term infant? Selective neuronal necrosis occurring in the watershed areas of the brain. What is the second type of injury? Gyries remaining intact, sulci getting scarred, resulting in a typical mushroom shaped gyries. This is also known as olighyrias. This is how they are looking. So when you do a brain imaging, the white arrow portion, you can see the white arrow portion. This is how a mushroom shaped gyri will look. So the moment you get this type of a picture on an MRI or a CT, you immediately know this is a child who has possibly suffered a birth asphyxia and his brain has got damaged. The third type of injury that can occur in the term child is a condition which is known as status marmoratus. This again is a selective neuronal necrosis. I told you selective necrosis of the neurons because of ischemia. But now the selective necrosis of the neuron is occurring in the region of the basal ganglia. So it will lead to mottling of the basal ganglia. What will it cause? It will cause bilateral mottling of the basal ganglia. It will not be unilateral, it will be bilateral. Just see, it is bilateral. It is not unilateral, it is on both sides. In PG entrance exams, this question has been asked, which of the following is a wrong statement about status marmoratus? And one of the choices is unilateral mottling of the basal ganglia occurs. This is wrong, it is both sides. It is bilateral mottling of the basal ganglia which occurs. So when the selective neuronal necrosis occurs in the watershed areas of the brain, it results in watershed infarcts. When they occur in the sulci, so sulcus gets scarred, then it is known as a mushroom shaped gyris. And when these neuronal necrosis occur in the basal ganglia, then it is known as status marmoratus. What is it called? Status marmoratus. So basal ganglia primarily getting infected. Now, one thing that you would like to know is that although ischemia is the main cause of status marmoratus, that means basal ganglia getting affected, is there any other injury that you know of? Any other injury that you know of which can occur in the brain of a newborn and specifically damages the basal ganglia? Any other injury? Ischemia, we are talking about ischemic encephalopathy. So here we are talking about ischemia. But can you tell me any other injury that can occur to the brain of a newborn and specifically damages the basal ganglia, leading to Status marmoratus. Yes, it is kernicterus. Very high amount of serum bilirubin entering into the brain. Kernicterus always damages the basal ganglia. So although ischemic injuries can frequently lead to status marmoratus is more commonly associated with kernicterus. What is kernicterus? High amount of bilirubin entering into the brain. Why do we give phototherapy? Next topic is neonatal jaundice. Why do we give phototherapies in newborns? We give phototherapies in newborns because newborns, if we do not give phototherapy, bilirubin will not reduce. And this bilirubin can cross the blood-brain barrier, enter the brain, and can completely damage the basal ganglia. So status marmoratus is more commonly a manifestation of kernicterus. It is a manifestation of hypoxemic ischemic encephalopathy, but it is more commonly a manifestation of kernicterus. So three types of injuries, once again repeating, seen in term infants because of hypoxic ischemic encephalopathy. Which are the three types of injuries? Selective neuronal necrosis occurring in the watershed areas of the brain, watershed infarcts, also known as parasagittal injuries. Second, formation of mushroom-shaped gyres, which is known as oligarias. And third, selective neuronal necrosis in the basal ganglia, which is also known as status marmoratus. It is leading to bilateral mottling of the basal ganglia. All the three are type of injuries that occur in the brain of a term infant. When it comes to the brain of a preterm infant, we have only one type of injury that is seen, which is known as periventricular leukomalacia. Just pay attention now to what I am saying. Now I am talking about a preterm infant. So whenever HIE, hypoxemic ischemic encephalopathy, occurs in the brain of a preterm infant, what will happen? Please pay attention here. See, these are the lateral ventricles of the brain. So this is the lateral ventricles of the brain. You know the ventricles of the brain. This is the third ventricle of the brain. And this is the fourth ventricle of the brain. So what happens is, just around the ventricles, you have this crisscross area, which is referred to as the white matter of the brain. So this white matter of the brain on both sides, please try to understand. White matter of the brain on both sides is trying to give shape to the brain. So the ventricles actually are in shape because from both the sides, the white matter is pushing the ventricles. That is why the ventricles remain in shape. So it is because of the white matter around the ventricles, which is pushing the ventricles inside, and that is why the ventricles remain in shape. Now, whenever hypoxic ischemic encephalopathy occurs, which means there is ischemia to the brain, this white matter starts to get necrosed because this do not get enough amount of blood. So this white matter around the ventricles start to get necrosed. Now just pay attention. White matter, leuco. Around the ventricles, periventricular. White matter, leuco. Around the ventricles, periventricular, necrosed, malacia. Just combine them together. First, I use the word periventricular. Second, I use the word leuco. Third, I use the word malacia. What we get is a periventricular leukomalacia. So what is periventricular leukomalacia? Periventricular leukomalacia is damage to the white matter around the ventricles, resulting in the support that they were giving to the ventricles getting removed. So now there is no support around the ventricles. The white matter have got necrosed. As a result, ventricles start increasing in size. Now, this increase in size is not because of the increase in pressure inside the ventricles. It is because of loss of support outside the ventricles. This increase in the size of the ventricles is known as hydrocephalus, but it is a type of a normal pressure hydrocephalus because it is not due to increase in the pressure inside the brain. What is this normal pressure hydrocephalus called? It is also known as hydrocephalus ex vacuum. These are the two important injuries that are known to occur as a result of hypoxemic ischemic encephalopathy in the brain of a preterm child. What is the injury? White matter necrosis around the ventricles, periventricular leukomalacia. Periventricular means around the ventricles, leuco means white matter, malacia means necrosis of that white matter. And as soon as this white matter necrosis happens, the white matter no longer exists. So the support it was giving to the ventricles gets removed. So as a result, the ventricles start expanding in size. Expansion of the ventricles is known as hydrocephalus, but this is not a hydrocephalus because of an increase in the pressure inside the ventricles. So it is not a raised pressure hydrocephalus, it is a normal pressure hydrocephalus, which is known as hydrocephalus ex vacuum. Right? So I hope you have understood this. Quickly revising, HI is basically damage to the brain because of birth asphyxia. The damage can occur in the brain of a term infant and can occur in the brain of a preterm infant. The damage which occurs in the brain of a term infant is selective neuronal necrosis occur in the watershed areas of the brain called as watershed infarcts. Second damage to the brain is the formation of mushroom-shaped gyres. Which is also known as oliguarias. And the third damage is the formation of status marmoratus, which is selective neuronal necrosis occurring in the basal ganglia. But I told you status marmoratus is more commonly seen in kernicterus, damage to the basal ganglia. What is the only type of injury that we see in preterm infants? It is a periventricular leukomalacia, which leads to which type of hydrocephalus? A normal pressure hydrocephalus, which is known as hydrocephalus ex vacuum. So, most common ischemic brain injury in preterm infants. Please see the question carefully. Most common ischemic brain injury seen in preterm infants is a periventricular leukomalacia. What is the most common ischemic brain injury which is seen in preterm infants? Most common ischemic brain injury seen in preterm infants, it is PVL, periventricular leukomalacia. That is in fact usually the only type of injury that occurs in preterm infants. Periventricular leukomalacia. Peri around, ventricular around the ventricles, leuco white matter, malacia liquefaction of this white matter. The type of ischemic brain injuries in term infants, watershed infarcts, mushroom-shaped gyres, and status marmoratus. But preterm infants, only one, periventricular leukomalacia. So whenever brain gets affected, these are the things that start to happen in the brain. And when the brain gets affected, that means different types of injuries which are occurring, ischemic injuries which are occurring in the brain of a term and a preterm child when brain finally gets infected. So all these injuries are occurring inside the brain. You are not getting to see these injuries. You can only see these injuries when you do an MRI like this. But how will the child manifest? You are sitting in the ICU or you are sitting in the OPD. How will the child manifest when the brain of the child starts showing hypoxic ischemic encephalopathy? One of the most common manifestation in this child will be a neonatal seizure. So what is the most common manifestation? It is neonatal seizures. This is the most common manifestation. Most common manifestation of HIE, hypoxic ischemic encephalopathy. Most common manifestation is neonatal seizures. So the child will start to present with seizures. Normally neonatal seizures, there are 5 important and 1 less important cause. The causes of neonatal seizures, are given by 5H and 1I. 5H, 1I. So which are the H5H which are cause of neonatal seizures? Hypoglycemia. So neonatal hypoglycemia can cause neonatal seizures. Neonatal hypocalcemia will cause neonatal seizures. Then neonatal hypomagnesemia can cause neonatal seizures. Then hypoxia. We are talking about hypoxia, ischemia. So this can also be a cause of neonatal seizure. So HIE, hypoxemic ischemic encephalopathy, is an important cause of neonatal seizures. And hemorrhage inside the brain, bleeding inside the brain can also cause neonatal seizures. And which is 1I? The I is infections, meningitis. So 5H, 1I are the important causes of neonatal seizures. Hypoglycemia, hypocalcemia, hypomagnesemia, hypoxia, hemorrhage, and 1I is infections. These are the 5 important causes of neonatal seizures. Right? So these are the 5 important H and 1I which can cause neonatal seizures: hypoglycemia, hypocalcemia, hypomagnesemia, hypoxia or hypoxemic ischemic encephalopathy. That's a topic that we are discussing. Hemorrhage and infections, hemorrhage inside the brain and infections. Now, just a few other important things that I would like to discuss here about neonatal seizures. I've just tried to summarize all the important points. Which is overall the most common cause of neonatal seizures? It is always hypoxic ischemic encephalopathy. So hypoxia or hypoxic ischemic encephalopathy is the most common cause of neonatal seizures. I told you the causes: hypoxia, hypoglycemia, hypocalcemia, hypomagnesemia, hemorrhage, infections. Among all of these, the most common single cause of neonatal seizures is HIE, hypoxic ischemic encephalopathy. Similarly, hypoxia or hypoxic ischemic encephalopathy is also the most common cause of neonatal seizure occurring in the first 24 hours of life. Neonatal seizure in the first 24 hours of life. The most common cause possibly again is hypoxic ischemic encephalopathy. Then, what is the most common type of neonatal seizures? Now, in children, you normally get generalized tonic-clonic seizures, partial seizures. But in the case of newborns, you do not get generalized tonic-clonic seizures. The reason is myelination of the brain is incomplete. So, any seizure activity that starts in the brain will not spread rapidly to the other parts of the brain. So, what will happen is these children is just subtle seizures. Subtle seizures means, for example, one finger and the twitching of the one finger happening. This is basically the most common type of neonatal seizures, subtle seizures. Generalized tonic-clonic seizures almost never occurs in the case of a neonate because the seizure, once it starts,